Welcome to the deep dive. We're here to take really complex clinical evidence, those huge systematic reviews and data syntheses, and basically pull out the essential bits, the actionable insights for you.
Exactly. And today we're tackling something incredibly common, happens millions and millions of times globally every year.
Right. We're talking about giving supplemental oxygen to patients having surgery.
Precisely. This deep dive is all about perioperative oxygen therapy, the oxygen given before, during, and importantly, after an operation. It feels like such a standard basic part of care, right?
Absolutely. Foundational.
But as the research we're digging into today shows, there's actually a surprising amount of, well, clinical uncertainty, real questions about which specific strategies actually help patients the most.
And crucially, which ones might even be causing harm we didn't fully appreciate.
Exactly. It seems almost weird to question giving oxygen. I mean, it's essential for life,
Yeah.
obviously. But the difference we're exploring today isn't about withholding necessary oxygen. It's about supplemental strategies, like using really high concentrations or these more advanced delivery methods after surgery compared to just standard care.
Okay. So our mission then is to try and clarify some of this uncertainty.
That's the goal. We're using the highest quality evidence we could find, this big overview, to really understand what works and what doesn't.
And the stakes are high here, aren't they? For anyone listening, whether you're prepping for a briefing or just curious about surgery, it's worth understanding just how common problems are after operations.
They really are. Postoperative complications are, frankly, far too common. Think about breathing problems, postoperative pulmonary complications, or PPCs. Depending on how you define risk and which studies you look at, these can affect anywhere from, say, 9% up to a massive 40% of patients.
40%, that's huge. That must have a massive impact on recovery.
Oh, absolutely. It's a huge burden. And then there's the infection risk,
Surgical site infections, SSIs, always a major concern after any procedure.
a huge concern. SSIs complicate somewhere between 10 and 20% of operations. Think about that. Maybe 1 in 5 or 1 in 10 surgeries.
Wow.
And just to put that in context for, say, the UK system SSI is the third most common healthcare-associated infection in England. In some reports, it affects almost 16% of patients.
16%. And these aren't just minor issues, right? They lead to real suffering.
Definitely. More suffering for the patient, higher mortality rates, much longer hospital stays.
Which means higher costs, obviously.
Yeah.
But there's that bigger picture issue, too, the link to antimicrobial resistance.
Yes, that's a critical point. SSIs are a massive driver of the whole antimicrobial resistance, or AMR, crisis. It's terrifying, really.
How so?
But when a surgery leads to an infection, you often need powerful antibiotics, sometimes even those last resort drugs. Every time we use them, we increase the pressure for bacteria to evolve resistance.
Right. It fuels the cycle.
Exactly. There are projections, that the global economy could lose something like 100 trillion US dollars by 2050 just because of infections we can no longer treat effectively.
100 trillion. That's staggering.
It is. So refining something as seemingly basic as how we give oxygen, if it can prevent even a small fraction of these SSIs, well, that's not just good patient care, it's vital for global public health.
That really frames why this matters so much. Okay, so the analysis we're using today, it's based on what's called an overview of systematic reviews and meta-analyses. Sounds pretty comprehensive.
It is. It's about as high up the evidence ladder as you can get.
And what specific oxygen strategies are we comparing within that big evidence base?
We're drilling down into 3 core comparisons that are used all over the world. First is giving a high concentration of oxygen, usually around 80%. That's called high FiO2, better than the standard lower concentration, maybe 30–35%.
Okay, high versus standard concentration during surgery. What's next?
Second, after the operation, is using postoperative high-flow nasal oxygen, or HFNO, that's oxygen, through little tubes in the nose, but at high flow rates better than just standard conventional oxygen therapy, COT.
Right, HFNO versus standard masks or prongs.
Oh.
And the third.
The third strategy is also postoperative, comparing non-invasive ventilation, or NIV, think CPAP or BiPAP masks again, versus conventional oxygen therapy. So 2 different levels of advanced post-op support compared to the basic approach.
Got it. High FiO2 during surgery, then HFNO and NIV after surgery. That gives us a clear map. Okay, let's unpack this evidence base itself. Before we even get to the results, we really need to appreciate the strength of the source material. You said it's an overview of systematic reviews. What does that actually mean for us for the reliability of what we're about to discuss?
It means it's built on a really solid foundation. Think of it like building a house. The researchers didn't just start digging randomly. They first identified several existing high-quality systematic reviews on these topics, reviews that were already well-respected and comprehensive. They called these their anchoring reviews.
Okay, so they started with what was already known and trusted.
Exactly. That gave them a stable base.
Yeah.
Then, from that point, they did a massive update. They systematically searched for all the newly published randomized controlled trials, RCTs, that had come out since those anchoring reviews were done.
How much searching are we talking about?
A lot. They screened, let me check the number. Yeah, 3,279 unique records after they removed duplicates. And from that, they eventually incorporated the data from 13 brand new RCTs into the analysis.
Wow.
So this approach, combining the rigor of existing reviews with the very latest trial data, is designed specifically to minimize bias and give us the most current, reliable picture possible, especially in a field like this, where new studies are always emerging.
Right. So given they went to all that effort to be rigorous and get the best evidence, I was struck by how cautious the language is in the findings. You see phrases like may result in or probably results in. It almost sounds like they're hedging. Why not just say it works or it doesn't work?
That's a really important point, that cautious language isn't them being wishy-washy. It's actually a sign of incredible discipline. They're strictly following a framework called GRADE.
GRADE.
Yeah, GRADE. It stands for Grading of Recommendations, Assessment, Development, and Evaluation. It's a systematic way to rate how confident we can be in the evidence for each specific outcome.
Okay, so the language directly reflects the assessed quality of the evidence.
Precisely. If the evidence has limitations, maybe the original trials had flaws, or the results across trials were inconsistent, or there just weren't enough patients or events studied, then the GRADE system forces you to use more ambiguous language. It's about accurately conveying that level of uncertainty.
Can you walk us through those levels? What kind of language maps to what level of certainty?
Sure. GRADE has 4 main levels: high, moderate, low, and very low certainty. If the evidence is high certainty, they feel confident saying something results in an effect.
Okay. Strong statement for strong evidence.
Right. If it drops to moderate certainty, the language softens a bit, like likely results in or probably results in.
Still pretty confident, but acknowledging some doubt.
Exactly. But then, if the quality drops further to low certainty, maybe because of bias risk in the studies or because results are all over the place, they have to use that really cautious phrasing, may result in.
May result in. Got it. And very low certainty.
Very low certainty means we have very little confidence at all in the effect estimate. The true effect is likely to be substantially different. The language there is extremely guarded.
That makes sense. It's translating statistical confidence or lack thereof into careful wording.
Okay, let's talk numbers then, because it's not just if there's an effect, but how big it is. You often see risk ratios, RR, reported.
Yeah, relative risk.
But this review really emphasizes absolute risk difference. Why is looking at the absolute change so critical when you're making clinical decisions?
Absolutely vital, because relative risk can be really misleading, especially for uncommon events. Imagine, say, a rare complication that normally affects only 1 in 10,000 people.
Okay.
Now, imagine a new treatment cuts that risk by 50%. That sounds amazing, right? A 50% reduction. Yeah, sounds great.
But what does it mean in absolute terms? You've gone from 1 in 10,000 to 0.5 in 10,000. You've prevented one event for every 20,000 people treated. The absolute difference is tiny, almost negligible in practice.
Ah, I see. The relative number looked impressive, but the actual impact is minimal.
Exactly. So the advisory panel for this overview focused squarely on the risk difference, or RD. That's the simple, absolute difference in the percentage of patients who experience the outcome between the two groups.
And did they set specific thresholds for what counts as a meaningful difference? Because a 1% absolute difference might not be that big a deal for something.
They did, and this is really helpful. They predefined what they considered clinically important. An absolute risk difference, RD, of 1% was considered small.
Okay, small.
An RD of 2.5% was considered moderate.
Moderate.
And an RD of 5% or more was considered a large difference in absolute risk.
Right, so 1%, 2.5%, 5% small, moderate, large. That gives us a benchmark.
It does. It anchors everything back to real-world impact. So if a treatment reduces, say, postoperative nausea by 1.2% RD, okay, that's statistically maybe different, but clinically small based on their definition.
Right.
But if another treatment reduces the need for reintubation by 5.5% RD, that hits their large threshold. That's a big deal for the patient and the healthcare system.
Okay, that's super helpful. So the message for anyone listening is don't just look at the percentage reduction, look for that absolute risk difference and compare it to those 2.5% moderate and 5% large thresholds.
Absolutely. It helps you filter the noise and focus on what really matters clinically.
Now, one more methodological point before we get to the results.
Okay.
We have to talk about publication bias.
Ah, yes, the file drawer problem.
Mm,
Studies with negative or null results often don't get published.
exactly. Or sometimes researchers might selectively report only the outcomes that look good. To check for this, researchers often use something called a funnel plot. But to do that reliably, you generally need at least 10 trials for each comparison you're looking at. Makes sense. You need enough data points to see if the plot looks symmetrical or skewed. So in this massive overview, how many of the comparisons actually had enough trials? That minimum of 10.
Fewer than half.
Fewer than half. Wow.
Yeah. So for many of the outcomes we're about to discuss, we simply can't rule out the possibility that publication bias or selective outcome reporting might be influencing the results we see. The true effect could be smaller or maybe even non-existent if all the unpublished negative trials were included.
So that adds another layer of caution we need to apply.
It does. And connected to that is this idea of trial sequential analysis, or TSA.
Right, you mentioned that earlier. TSA tells you if you've actually collected enough data, enough patients to be sure about a result.
That's the gist of it. TSA calculates what's called the required information size, basically. How many patients you'd need in total to be really confident that an observed effect isn't just due to random chance, especially if you're stopping trials early. If the total number of patients in all the trials combined doesn't meet that required size, then even if you see a statistically significant result, the TSA warns you that it might be unreliable. It could disappear or even reverse if more data were collected.
And you hinted we'll see an example where this is really important.
We will. For one of the key, most debated questions in this whole field, the TSA showed that the analysis was still short by about 7,000 patients.
7,000 patients short.
Yep. That gives you a really concrete idea of the scale of the remaining uncertainty, the size of the knowledge gap we're still trying to fill.
Incredible. Okay, so rigorous methodology, grade language respecting certainty, focus on absolute risk differences, awareness of publication bias, and this TSA concept telling us when we still need more data. That's a fantastic setup. Let's get into the findings.
All right, now that we've got the ground rules set, understanding the evidence quality, the language, the numbers, let's dive into the actual clinical findings. And we have to start with probably the highest profile debate in this area. Using a high concentration of inspired oxygen, that's 80% IO2, versus the standard 30-35%. This was pushed for years, wasn't it, as a way to prevent surgical site infections, SSIs.
It absolutely was. It made it into guidelines, became pretty standard practice in many places, all based on the idea that flooding the tissues with oxygen would help immune cells kill bacteria more effectively at the surgical site.
Makes sense physiologically, perhaps. So did this huge evidence synthesis, pulling together all those trials, finally confirm that benefit for preventing SSIs? Well, the short answer is mostly no. The big picture, this panoramic meta-analysis covering 24 trials and almost 10,000 patients, 9,725 participants, to be precise.
Okay, nearly 10,000. That's a lot of data.
It is. And what it suggests is that using high FiO2 results in little to no difference in SSIs compared to using standard FiO2.
Little to no difference. Can you give us the numbers on that?
Sure. The overall risk ratio is 0.91. So that suggests maybe a 9% relative reduction in infection risk, which sounds okay, maybe.
Yeah, 9% sounds potentially useful.
But then you look at the absolute risk difference, the RD, and that was only 1.2% lower in the high FiO2 group.
1.2% absolute reduction.
Okay.
And remembering our thresholds, 1% was defined as small.
Exactly. So at the very best, if you believe this number, it's a small potential benefit.
And what about the certainty? Given the debate, I'm guessing it wasn't high certainty.
You guessed correctly. This finding comes with low certainty evidence.
Low certainty. So we can't even be that confident in that small 1.2% benefit.
Precisely. It's far from conclusive. And the reason for that low certainty becomes crystal clear when you look at the trial sequential analysis, the TSA we talked about.
Ah, right. Did it meet the required information size?
Not even close. The TSA calculated that to be definitive about the effect of high O2 on SSI, you'd need data from about 14,468 patients.
14,500, and we have data on
Just under 10,000. So we are still short by roughly 7,000 patients.
7,000 patients needed just to get a clear yes or no on preventing infection with high oxygen.
That's the gap. Until we have that data, the current evidence is fundamentally inconclusive. The true effect could still favor high FiO2 slightly, or it could favor standard FiO2, or there could be truly no difference. We just don't know for sure.
That is genuinely astonishing. Something used so routinely based on a plausible idea, and we're still thousands of patients away from knowing if it actually works for its main proposed benefit. It really does put clinicians in a tough spot, doesn't it?
It creates huge tension. You have historical guidelines, maybe based on earlier, smaller studies, or physiological reasoning, bumping up against this massive synthesis of current evidence that says, hold on, we're really not sure.
Yeah. Now, you said the overall picture was little to no difference. Did they look at specific subgroups? Maybe it works better in certain types of surgery?
They did. And the subgroup analyses offered, well, a bit of a mixed picture, maybe some hints, but nothing definitive.
Okay, what did they find?
There was one statistically significant subgroup difference, and it was borderline significant, p 0.05, based on the type of surgery performed.
Interesting. Which types?
They saw a potential SSI reduction, favoring high FiO2, specifically in patients having colorectal surgery and other types of intra-abdominal surgery.
Okay, gut surgery, basically.
Right. But importantly, they did not see that same potential benefit in patients having cesarean sections.
Huh. So maybe it's something specific about operating within the abdomen, maybe higher contamination risk where extra oxygen might help. Whereas a C-section, while major surgery, is perhaps cleaner or different tissue.
That's the speculation. It raises the possibility that if there's a benefit from high FiO2 for SSI, it might be quite specific to certain contexts, like surgeries with a higher baseline risk of bacterial contamination.
Any other subgroups show anything?
They noted a couple of other exploratory findings. For instance, the suggestion of benefit seems stronger in emergency surgery settings.
Okay, maybe sicker patients, more contamination again.
Possibly. And also, the benefit seemed clearer in the trials that were rated as having a low risk of bias overall. But again, the authors stress, and we need to stress, these are just exploratory subgroup findings. They're hypothesis generating at best, not solid proof. You can't make firm recommendations based on them.
Right. Treat with extreme caution. So overall for SSI, uncertain, likely small benefit at best, maybe only in specific surgeries like abdominal ones. And we still need thousands more patients to be sure.
That sums it up perfectly. Now, that's the potential benefit side. We absolutely have to turn to the potential harm side of the equation.
Okay. If high FiO2 isn't clearly helping prevent infections, could it actually be hurting patients in other ways?
This is arguably the most critical finding from this whole section of the review. When they looked at a major potential harm, atelectasis, which is partial collapse of the lung.
Right, lung collapse. Not good.
Not good at all. The evidence, even though it's also rated as low certainty, suggests that using high FiO2 may result in a large increase in the incidence of atelectasis.
A large increase. Okay, we need the numbers on that. How large?
The risk ratio was 1.47. That means almost a 50% relative increase in the risk of developing atelectasis if you get high FiO2 compared to standard.
Okay, nearly 1.5 times the risk. What about the absolute difference?
The absolute risk difference, the RD, was 6.5% higher in the high FiO2 group.
6.5%. Okay, let's go back to our thresholds. 1% small, 2.5% moderate, 5% or more was large.
Exactly. So 6.5% RD falls squarely into the large absolute harm category according to their own predefined thresholds.
Wow. So a potentially large increase in lung collapse. But wait, you said this finding is also low certainty evidence.
Yeah.
If the SSI benefit is low certainty and we're hesitant about it, why should we take this low certainty harm signal so seriously?
That's the crucial clinical judgment call, isn't it? There are a couple of reasons why this atelectasis signal, despite being low certainty statistically, carries more weight clinically. First, the magnitude of the observed effect is large. That 6.5% absolute difference is substantial.
Okay, size matters.
Size matters. And second, perhaps more importantly, this finding aligns perfectly with well-understood physiology. There's a known mechanism for how high oxygen can cause lung collapse.
Ah, you mean absorption atelectasis.
Exactly. Absorption atelectasis, sometimes called nitrogen washout. Can I explain that briefly?
Please do.
Okay, so normally the air we breathe is mostly nitrogen, about 79%. Nitrogen is pretty inert. It doesn't get absorbed into the blood very easily. It acts like a splint inside the tiny air sacs in our lungs, the alveoli, helping to keep them open, especially the ones that might not be perfectly ventilated all the time.
Right, it provides structural support almost.
Sort of, yeah. Now, what happens if you replace that nitrogen-rich air with 80% oxygen? You effectively wash out most of that nitrogen splint.
Okay.
Now, if blood flow continues to those alveoli, But for some reason, ventilation to that specific tiny area temporarily stops or slows down, which can easily happen during anesthesia or post-operatively, what happens to that nearly pure oxygen.
It gets absorbed into the blood really quickly.
Very quickly. Oxygen moves rapidly from the alveolus into the bloodstream. And because there's no nitrogen left behind to hold the space open, the alveolus just collapses like a deflated balloon.
Okay, that makes perfect sense physiologically.
It does. So when you have a large observed effect size, that's 6.5% RD, even if the statistical certainty is low due to trial limitations, and you have a very plausible biological mechanism that explains exactly why it would happen.
Then you have to take that harm signal much more seriously.
Absolutely. You weigh that uncertain, small 1.2% potential benefit for SSI against this biologically plausible, potentially large 6.5% harm for atelectasis. And suddenly, the risk-benefit balance for routinely using 80% IOT looks, well, pretty unfavorable.
Yeah, it really tips the scales towards caution. What about other breathing problems? Did high FiO2 affect things like overall pulmonary complications or pneumonia or respiratory failure?
For those other outcomes, the picture was much more neutral, but also very uncertain. For overall postoperative pulmonary complications, PPCs, the evidence suggested little to no difference, but it was very uncertain. Same for pneumonia, the risk ratio was 1.13, suggesting maybe a slight increase, but again, low certainty, little to no difference overall. And for respiratory failure, RR 1.03, basically no difference, low certainty again.
So no clear signal either way for those specific complications, mostly just uncertainty.
Right. The atelectasis finding really stands out as the main respiratory concern.
And what about non-respiratory outcomes? Did high FiO2 impact how long people stayed in hospital or mortality or things like nausea?
No, the evidence consistently showed little to no difference for all of those major non-respiratory outcomes. That includes in-hospital or 30-day mortality. The RR was 1.21, but low certainty, crossing 1.0. Unplanned ICU admissions, rates of postoperative nausea and vomiting, PONV, and the overall length of hospital stay.
Okay, so if we boil down this whole high FiO2 section, what's the bottom line?
The bottom line is, the current evidence base is really insufficient to support the routine use of 80% IO2 just for the sake of preventing infections, especially when you might only need, say, 40% or 50% IO2 to keep the patient's oxygen saturation perfectly normal.
Because the benefit for infection is small and uncertain.
Very uncertain, and possibly only in specific surgeries.
While the risk of harm, specifically lung collapse or atelectasis, is potentially large and biologically plausible.
Exactly. And there's no clear evidence it helps with survival or getting out of hospital faster. So clinicians really need to weigh that uncertain benefit against that potential harm for each patient, rather than just applying 80% oxygen across the board. Caution seems warranted.
Okay, let's shift gears now. We've talked about the concentration of oxygen during surgery. Now let's focus on how oxygen is delivered after the operation, in the postoperative recovery phase. We're starting with something called high-flow nasal oxygen, or HFNO. Can you first just define HFNO for us? How is it different from the standard oxygen mask or nasal prongs people might be familiar with?
Sure. Conventional oxygen therapy, or COT, is what most people picture simple nasal prongs or a basic face mask delivering oxygen, usually at relatively low flow rates, maybe up to 6 or sometimes 15 liters per minute.
Right, the standard setup.
HFNO is quite different. It's a more sophisticated system. It uses special, soft nasal cannulas, but it delivers oxygen, or an air-oxygen mix that's been heated and humidified at much higher flow rates.
Right.
We're talking maybe 30, 40, 50, even 60 liters per minute.
Wow, that's a lot more flow. What's the point of such high flow?
There's several proposed benefits. The high flow helps to wash out the dead space in the upper airway, the area where air sits but doesn't participate in gas exchange. This can make breathing more efficient.
Okay.
It also provides a bit of positive pressure, which might help keep the airways open, though less pressure than NIV. And because the gas is warmed and humidified, it's generally much more comfortable and tolerable for patients than dry, cold oxygen at high flows from a standard mask. Plus, it can deliver a more reliable and consistent concentration of oxygen, FiO2, if needed.
Okay, so it's a more advanced, potentially more comfortable way to deliver higher flows and maybe more consistent oxygen levels. So the big question, compared to just standard COT, how unactive is HFNO in preventing problems after surgery? What did the overview find?
The updated meta-analysis looked at 16 RCTs with just over 2,200 patients in total, and it found one main potential benefit. It suggested that using HFNO may reduce the need for patients to have their respiratory support escalated.
Escalated. What does that mean in practice?
It means avoiding the need to step up to more intensive support. So avoiding having to switch the patient to non-invasive ventilation,
Hmm.
NIV, or needing emergency intubation and mechanical ventilation, or having to transfer them unexpectedly to a higher level of care like an ICU or a high dependency unit just for respiratory reasons.
Ah, okay. So HFNO might help keep patients stable on simpler support, avoiding those more serious interventions. That sounds pretty useful, both for the patient and for hospital resources.
It does sound potentially very useful.
What was the size of that effect? Was it small, moderate, large?
The risk ratio is 0.61. That suggests a relative reduction of about 39% in the risk of needing escalation.
Nearly 40% relative reduction.
Okay.
And the absolute difference?
The absolute risk difference, the RD, was 7.8% lower with HFNO.
7.8% lower. Okay, comparing that to our thresholds. 1% small, 2.5% moderate, 5% large. So 7.8%
It
is...
falls into the moderate effect category. It's a substantial potential reduction in needing to escalate care.
A moderate effect size is definitely promising, but I sense a but coming. Knowing what we learned about GRADE, what was the certainty of this evidence?
Ah, yes. The but. Unfortunately, the evidence supporting finding this moderate reduction in escalation is rated as very low certainty.
Oh, very low. That's the bottom rung, isn't it?
It is. It means we have very little confidence that this 7.8% reduction is the true effect. The real effect could be much smaller or even non-existent.
Why such low certainty? What were the problems with the studies?
It was mainly down to two things, common issues in these kinds of trials. First, many of the included RCTs were quite small. They didn't have large numbers of patients.
Okay, small sample sizes.
And second, there were significant issues with imprecision. That basically means the results were statistically noisy. The confidence interval around that 7.8% risk difference was very wide, meaning the true value could plausibly be anywhere from a much larger benefit to no benefit at all.
Right. So while the number looks good on paper, 7.8% reduction, the statistical confidence around that number is just too weak right now.
Exactly. We're hopeful, based on this signal, that HFNO might help avoid escalation, but we just can't be confident about it yet based on the current evidence.
That's quite disappointing, especially because I remember some earlier reviews, maybe smaller ones, seemed quite positive about HFNO, sometimes even suggesting it reduced the need for reintubation. Did this big updated overview find any support for that? Does HFNO prevent patients from needing to be put back on a ventilator?
Yeah, that was a key question. And unfortunately, the answer from this comprehensive synthesis, which included those 13 newest RCTs, was no. The analysis suggests that HFNO results in little to no difference in the rate of reintubation compared to conventional oxygen therapy. The risk ratio was 0.78, but the confidence interval was wide and crossed 1.0.
Little to no difference in reintubation. That's a really critical finding, isn't it? Because it suggests that while HFNO might buy some time, might make the patient feel better temporarily and maybe avoid an immediate escalation,
Right.
it might not actually prevent the underlying respiratory problem from progressing to the point where they ultimately need intubation anyway.
That's a very fair interpretation of the current data. It might delay or mask the problem in some cases without fixing it.
Yeah.
And again, this finding about reintubation remains highly uncertain. Why? Because the trial sequential analysis, the TSA.
Let me guess, it didn't meet the required information size.
You got it. For the outcome of reintubation, the TSA calculated a required size of over 16,000 patients. 16,461.
16,000. And how many did we have in the HFNO trials for this outcome?
Far fewer than that. So just like with SSI and high FiO2, we are thousands of patients short of having a definitive answer on whether HFNO actually prevents reintubation. The current data just isn't powerful enough to say for sure.
Wow. So much uncertainty persists. What about the really big outcomes? Did HFNO affect mortality? Or did it at least improve oxygen levels, prevent hypoxemia?
For mortality, the finding was similar to reintubation, little to no difference compared to conventional oxygen therapy. The risk ratio was 0.78 again, but this was based on low certainty evidence, so still quite uncertain.
Okay, no clear survival benefit shown. And oxygen levels.
Hypoxemia.
There was a suggestion that HFNO may reduce the incidence of postoperative hypoxemia. That's the actual measured drop in blood oxygen saturation. The risk ratio was 0.79, but...
Let me guess. Very uncertain evidence again.
Bingo. Very uncertain evidence for reducing hypoxemia as well. Okay, so putting it all together for HFNO, we have this tantalizing potential moderate benefit in reducing the immediate need to escalate care, but that's based on very shaky, very low certainty evidence. And for the harder, more important outcomes like preventing reintubation or death, or even just reliably preventing low oxygen levels, The evidence currently suggests little to no difference and is generally low or very low certainty anyway.
That is a perfect summary of the current state of play for postoperative HFNO based on this massive overview. It's an intervention with promise, but the high-quality evidence to firmly support its routine use just isn't there yet.
Did they mention the context, like what kinds of patients were mostly studied?
Yes, that's relevant. The report notes that the majority of the included trials were conducted in patients undergoing cardiac surgery.
Ah, okay. So maybe the results are most applicable to that group.
Potentially. The researchers did try to look for subgroups where HFNO might perform better, specifically for that outcome of preventing escalation. They looked at different types of surgery, like cardiac versus abdominal versus thoracic, different baseline risks of pulmonary complications, even different body mass index, BMI categories.
And did they find any group where HFNO seemed particularly helpful?
No. The subgroup analyses showed no credible subgroup effects. The signal that potential moderate benefit for escalation, albeit very uncertain, seemed pretty consistent across the different types of patients studied. It didn't seem to work dramatically better or worse in any specific group they could identify.
Interesting. So if it does work, it might work similarly across different high-risk patients, but the core problem remains that we're just not sure if it works reliably yet.
Precisely. More high-quality trials are definitely needed for HFNO.
All right, let's move on to the third and final strategy we're examining today, non-invasive ventilation, or NIV. You mentioned this is often seen as a step up from both conventional oxygen and HFNO. Can you quickly remind us what NIV involves?
Sure. NIV typically involves delivering pressurized air or oxygen mix through a tight-fitting mask, either a full-face mask or sometimes just a nasal mask. The key difference from HFNO is the deliberate application of positive pressure. This usually comes in two main forms: CPAP, which is continuous positive airway pressure.
Right, just one constant pressure level.
Exactly. Or BiPAP, which is bilevel positive airway pressure, where you have a higher pressure when the patient breathes in and a lower pressure when they breathe out. Both aim to physically splint the airways open, improve lung recruitment, and reduce the effort of breathing.
Okay, so it's more mechanically supportive than just high-flow oxygen. Given it's more intensive, how does NIV stack up against standard conventional oxygen therapy, COT, in the post-operative setting? Did the evidence show clearer benefits here compared to HFNO?
Yes, generally speaking, the evidence for NIV seems clearer and more robust, particularly for preventing lung complications.
Yeah.
Let's start with the big one. Overall postoperative pulmonary complications, PPCs.
Okay, the main breathing problems after surgery. What did NIV do for those?
The synthesis suggests that NIV may decrease PPCs quite significantly. The risk ratio was 0.62.
0.62, that's a substantial relative reduction, almost 40%. What about the absolute risk difference?
The absolute risk difference, the RD, was 12.2% lower with NIV compared to COT.
12.2%, that's huge. Remembering our thresholds, 5% was large. This is more than double that.
It is. It represents a really substantial moderate to large absolute reduction in the overall burden of postoperative lung complications.
Yeah.
Now, the certainty level for this finding was rated as low certainty.
Still low certainty.
Still low certainty, likely due to the variations between the trials or some bias concerns. But the sheer size of that effect, that 12.2% absolute reduction, makes it very clinically compelling, even with low certainty evidence. Cutting PPC risk by over 12% just by using NIV instead of standard oxygen. That's potentially transformative if true.
Absolutely. A 12% absolute risk reduction would be a major win. Okay, what about more severe forms of lung injury like ARDS, acute respiratory distress syndrome? Did NIV help prevent that specifically?
Yes, it did seem to help here as well, and importantly, with a higher level of certainty. The review found that NIV probably results in a slight reduction in the incidence of ARDS.
Probably results in, okay, that sounds like moderate certainty language.
Exactly. This finding is based on moderate certainty evidence. The risk ratio was 0.70.
So a 30% relative reduction in ARDS risk. What was the absolute reduction?
The absolute reduction, the RD, was more modest here, about 1.2% lower. So that falls into their slight reduction category.
Okay, slight, but with moderate confidence. That's still important, right? Preventing even a small number of ARDS cases is significant.
It absolutely is. ARDS is a devastating complication. So achieving moderate certainty that NIV offers even a slight reduction is a really positive finding for this intervention. It strengthens the case for using it.
Now, whenever we talk about using pressurized masks, especially tight-fitting ones, clinicians often have two big worries. One is just patient tolerance. Can people actually keep these masks on? But the more serious one is safety, particularly the risk of pulmonary aspiration, where stomach contents might get inhaled into the lungs because of the pressure. Did the review find any evidence that NIV increases these major risks?
This is perhaps where the evidence for NIV is most reassuring and provides the strongest message. The data clearly shows that NIV results in little to no difference in either overall mortality or in the rate of pulmonary aspiration compared to conventional oxygen therapy.
Little to no difference in death or aspiration. That's huge for safety. What was the certainty level for those findings?
This is the key point. For both mortality, risk ratio 0.91, and pulmonary aspiration, risk ratio 1.11. The findings of no difference are supported by high certainty evidence.
Yeah, high certainty. Okay, that's the top level. So we can be very confident that NIV, despite being more intensive, doesn't increase the risk of dying or the risk of this major aspiration complication.
Exactly. High certainty means further research is very unlikely to change our confidence in that estimate of effect. We can be pretty sure that NIV is safe in terms of these major adverse outcomes. The pooled absolute risk difference for mortality was tiny, just 0.1% lower with NIV, essentially zero.
So let's put that together. We have an intervention, NIV, that potentially offers a large reduction in overall lung complications, PPCs, probably offers a slight reduction in severe lung injury, ARDS, and we're highly certain it doesn't increase the risk of death or aspiration. That sounds like a pretty compelling package, doesn't it?
It really does. It creates a very strong risk-benefit profile, particularly for patients who are at high risk of developing pulmonary complications after surgery. The potential for significant benefit coupled with high certainty about its safety on major outcomes provides a solid justification for considering its use.
What about some of the other outcomes? Did NIV affect reintubation rates or pneumonia specifically?
For reintubation, the finding was similar to HFNO. NIV probably results in little to no difference in the reintubation rate. This finding was based on moderate certainty evidence.
Okay, so neither HFNO nor NIV seem to reliably prevent reintubation compared to standard oxygen based on current evidence.
That seems to be the case. For pneumonia specifically, NIV also showed little to no difference, although the certainty for that outcome was only low.
Any other benefits noted?
There was one other interesting finding. The evidence suggests NIV results in a slight reduction in unplanned ICU admissions. The risk ratio was 0.73, based on low certainty evidence.
Okay.
That translated to an absolute risk reduction of about 1.6%. It's possible this slight reduction in ICU transfers is related to NIV helping manage the less severe pulmonary complications better, preventing them from escalating to the point of needing ICU care, even if that doesn't prevent the most severe cases requiring reintubation.
That makes sense. It fits with the overall picture of reducing PPC severity. Now, one last check on NIV. Was its effectiveness consistent across different types of surgery, or was it like the high FiO2 hint? Maybe better in abdominal surgery, or maybe better in chest surgery?
Good question. They did look at that. The researchers performed subgroup analyses comparing outcomes in patients who had abdominal surgery versus those who had cardiothoracic surgery.
Yeah.
They found no credible subgroup effects for the main NIV outcomes like PPCs or ARDS.
Really? So, unlike that little signal for high FiO2 being maybe better in abdominal surgery, the benefits of NIV seemed consistent regardless of whether it was belly surgery or chest heart surgery.
That's what the analysis suggested. The moderate benefit of NIV in reducing PPCs and the slight benefit in reducing ARDS appear to be relatively stable across these different major surgical groups.
That's important too, right? It reinforces the idea that NIV could be a useful tool more broadly for high-risk patients, not just confined to one specific surgical specialty.
Exactly. It strengthens its potential utility as a more general postoperative respiratory support strategy for those identified as being at higher risk. So if we try to pull all of this together, synthesize this entire landscape of perioperative oxygen therapy, we really need to look at the overall evidence map that this huge overview provides. And I think the single most striking feature of that map, the thing that jumps out immediately, is just how much of it is colored by low or very low certainty evidence.
Right. That lack of certainty really is the dominant theme here, isn't it? Even for these incredibly common fundamental interventions that we use every single day in operating rooms and recovery areas around the world, we still lack definitive, high-confidence proof for many of the benefits or harms.
It's quite humbling, actually.
It really is. Okay, so let's quickly recap the main conclusions for each of the three strategies, keeping that uncertainty firmly in mind. Let's start with high FiO2, 80% during surgery.
Okay. For high FiO2, the bottom line is the evidence is insufficient to recommend using it routinely just to prevent infection. The potential benefit for reducing surgical site infection, SSI, seems small at best, only a 1.2% absolute risk difference, and that finding is based on low certainty evidence anyway,
And that uncertain small benefit has to be weighed against.
against a clear signal of potential harm, specifically a potentially large increase in atelectasis or lung collapse. The absolute risk difference there was 6.5% higher with high FiO2. Even though that's also low certainty, the size of the effect and the known physiological mechanism make it a serious concern.
So for high FiO2, uncertain benefit versus plausible, potentially large harm, caution advised.
Precisely. Now moving to postoperative support, starting with the less invasive option, high-flow nasal oxygen, HFNO.
Right. What's the summary for HFNO?
HFNO shows potential to reduce the need for escalating respiratory support. The effect size looked moderate, at 7.8% absolute risk reduction. However, and it's a big yet, however, the evidence supporting this is currently very uncertain, rated as very low certainty.
So a promising signal, but on very shaky ground.
Exactly. And importantly, the updated data failed to confirm earlier hopes that HFNO might prevent reintubation. For that, and for mortality, the evidence suggests little to no difference. So HFNO remains an intervention with potential, maybe, but it lacks solid evidential support for routine use right now.
Okay, and finally, the most robust option we discussed, postoperative non-invasive ventilation, NIV.
Yes, NIV definitely comes out looking the strongest from this overview. It offers the most consistent and positive findings. It shows a potential moderate to large reduction in overall postoperative pulmonary complications, PPCs.
Correct.
That was the 12.2% absolute risk reduction, albeit with low certainty.
And a reduction in ARDS.
And probably a slight reduction in ARDS, which was backed by moderate certainty evidence, so higher confidence there. And crucially,
the safety profile.
the safety profile. NIV comes with strong, high-certainty evidence showing it causes little to no difference in mortality or the risk of pulmonary aspiration.
So, for NIV, good evidence of benefit for lung complications, especially ARDS, combined with high certainty about its safety for major adverse events.
That's the package. It suggests NIV currently offers the best balance of likely benefit and known safety among these advanced postoperative respiratory support strategies, especially for patients you identify as being at high risk for complications.
That's a really clear synthesis. Now, the researchers who did all this work, they didn't just stop at summarizing what we know now. They also pointed out where the big gaps still are. They essentially gave us a roadmap for future research, didn't they? What do we still urgently need to find out?
The fundamental gap, the overarching need, is for more massive, really well-designed and well-conducted randomized controlled trials. We need trials that are specifically powered, meaning large enough to give us definitive answers on those crucial outcomes, like mortality, SSI, and overall PPCs.
And should these trials look at all surgical patients or focus more?
The review suggests either approach could work. You could try to run enormous trials across very broad surgical populations, or perhaps more efficiently, you could run large trials focused specifically on high-risk groups, patients having particularly complex surgery, or patients with significant comorbidities like obesity or COPD, or heart failure, where the event rates are higher and you might see effects more clearly with fewer total numbers.
Makes sense. Target the research where the problems are biggest. Let's just circle back for a moment to that specific number you mentioned earlier regarding the high FiO2 and SSI controversy. It really sticks in my mind as illustrating the scale of the challenge here.
You mean the 7,000 missing patients?
Yeah. The trial sequential analysis showed that to get a definitive answer on whether high oxygen prevents surgical site infections, we still need data from roughly 7,000 more patients than we currently have from all the trials combined.
It's a stark number, isn't it? It represents a huge undertaking, millions and millions of dollars or pounds in funding, incredible logistical coordination across possibly dozens of hospitals, maybe internationally, and likely years of patient recruitment and follow-up.
Oh, just to get a clear yes or no answer on one single, seemingly simple routine intervention.
It really highlights why medical progress, especially for common interventions where effects might be modest but still important at a population level, can sometimes feel frustratingly slow. Getting those definitive answers requires enormous sustained effort and resources.
Which brings us perfectly to our final provocative thought. Something for you, the listener, to mull over now that you understand this complex evidence landscape, probably better than many people out there. We've clearly established the massive clinical and economic burden of problems like SSIs and PPCs.
Huge burden.
We know that surgery is incredibly common. You mentioned 1 in 20 people in the UK has surgery each year, and that's mirrored globally, hundreds of millions of procedures. So here's the question. Why, when the human stakes are so incredibly high, we're talking about patient lives, suffering, disability, and the economic stakes are so high. Hospital resources, productivity losses, the global threat of antimicrobial resistance. Why is it so difficult to muster the collective will, the funding, the coordination to run the trials needed to collect those missing 7,000 patient data points for something as basic as oxygen administration?
It's a critical question. We have this fundamental intervention used everywhere, every day, and we still lack definitive answers on its core benefits and harms. The knowledge seems within reach. We know how to design the trials. We know roughly how many patients we need.
But bridging that gap seems almost insurmountable sometimes. What responsibility do we have as clinicians, as researchers, as policymakers, even just as informed members of society to really push for the resources and the collaboration needed to finally close these critical research gaps, especially for interventions that are as common, as basic, and yet still as poorly defined as the air we give our patients during and after surgery?
Something definitely worth reflecting on, considering the complex and often conflicting findings we've explored today.